today, we're looking at research that could change breast cancer screening for everyone.
A lot of the advances we've made in breast cancer really are about understanding that breast cancer is not one disease. It's many different diseases. In our highest risk group, where we were screening every 6 months, nobody had a stage 2B or higher cancer.
What were the results? 47,000 women.
Risk-based screening is better.
Better, not even the same.
It's better. We can't be screening those people all the time. That would be way over screening. That using these AI algorithms, to tell you, you can find the 10% of people who really need more screening. A genetic test today is cheaper than a mammogram.
And you only have to do it once.
I think it's really something that every woman should know.
Welcome back to Kicking Cancer's Ass, where we give you the insights, power, and hope you need with real stories, cutting-edge science, and proven suggestions. I'm Joelle Kaufman, and today we're looking at research that could change breast cancer screening for everyone, for your daughters, your granddaughters, everyone. In fact, 47,000 women just proved we can personalize screening based on your actual risk, not one-size-fits-all guidelines. And the visionary behind that study, the leader of it, joins me today. She's also my breast surgeon, Dr. Laura Esserman. She is a surgeon, a researcher, an innovator. She leads the UCSF Breast Cancer Center. She pioneered nipple-sparing mastectomies. She leads the Wisdom study, the I Spy study, and she founded the RiseUp for Breast Cancer and Women's Health Conference. Laura, Dr. Esserman, thanks for joining me.
Thanks for having me, Joelle.
It's good to see you. Well, let's go to that moment of insight. Can you walk us through what you saw that made you think we need to completely change how we screen for breast cancer?
I think there's a number of things that over the years, I think that, our hope was that by screening, what we would do is find many more early stage cancers and reduce the number of late stage cancers. And indeed, we found many more early stage cancers, but we did not see the reduction in late stage cancers that we should have seen. In addition, as you know, on the I Spy trial, we only have women with high-risk cancers who have stage 2 and 3 disease. If screening were so perfect, there would be no I Spy trial. There'd be no need for an I Spy trial. So clearly something was amiss. I teamed up with Ian Thompson in 2008, and we published in 2009 an article called Rethinking Screening. And what I tried to do was apply the lessons from prostate cancer screening, as everyone is familiar with this example that screening, while it can be effective in trying to reduce the chance of finding late-stage prostate cancer, they had a huge increase in early-stage cancers. And in fact, so much so that what was happening is that people were going to the OR having, increasing the mortality rate because people were having surgery that they didn't need. And if you took that early Gleason 3+3 or early stage cancers and you watched them with active surveillance, in fact, they did just as well as if you intervened right away. I started thinking about this. And then, of course, a lot of the advances we've made in breast cancer really are about understanding that breast cancer is not one disease. It's many different diseases, from very low-risk indolent disease to very high-risk, fast-growing cancers. So breast cancer is not one disease. One size doesn't fit all for treatment. So how is it we've now just taken and said, okay, now we're going to apply screening as if everyone has the same risk and everyone's at risk for the same cancer? That's what age-based screening, everyone starts at 40 and that's it. That made no sense to me. And every woman knows that one size doesn't fit all. We don't all go out and say, hey, can I have a pair of size 8 jeans, right? That's just, we might think that's a good thing, but it doesn't work. So I was really trying to think about how could I make a difference? And, I like to think breast cancer is not different. Every disease is this way, right? If you had an allergic reaction, that could be hay fever. It could be a bee sting, or it could be asthma or an anaphylactic reaction. We don't treat those things differently. And no one blinks an eye and thinks about that. And we try and prevent those things differently. So Then I thought, well, if we really want to make a difference on prevention and on screening, we have to do a better job of doing comprehensive risk assessment and then tailoring screening accordingly. And not only screening, but prevention. If you are at risk for hormone-positive breast cancer and high risk, there are lots of things that we can do today that could probably drop your risk in half.
Like what?
Like tamoxifen. And now we can use baby tamoxifen, which is a quarter of the dose. And that will absolutely drop the dose. And we're testing all kinds of new medicines to do that. You might make different choices about hormone replacement or many other things in your life if you knew what your risk was. And importantly, we cloned the genes for BRCA1 and 2 in 1996 and 1997. We have yet to do comprehensive testing in the population to find out who those people are. Now, only probably 2% of people really have those really high risk genes where you have an error in the gene and it puts you at 80% risk, as you yourself know.
I do.
Why are we not going out and trying to find the low-hanging fruit and say, wow, at the very least, let's find the people at the very highest risk, screen them more frequently, and figure this out. So that was really my point. We are not using all of the tools that we have at our disposal. And over time, for a lot of reasons, genetic testing has become very inexpensive. I mean, you can order a test that's very expensive or inexpensive. And, we partnered with someone who was really trying to make this accessible because the founder himself is a BRCA2 carrier, and this was his goal of trying to disseminate this. And we had a common interest in that. But I wanted to prove that we could do it differently because the U.S. Preventive Task Forces eventually changed their tune to say, okay, now every woman should get screened starting at 40, but every other year. But if you're at risk for a fast-growing cancer, you should be screened every 6 months. So none of this made sense to me. A lot of resistance in the radiology community that, this is going to be bad. We're going to put people at risk. We're going to kill women in their 40s. And I said, if you do a really good job of risk assessment, that shouldn't happen. Now, the radiology community wasn't going to support us, so we took it to women themselves, and we reached out and did this big comprehensive study across the United States, and we published the results and presented them a month ago. And
so
guess what?
Can you tell people what were the results? 47,000 women.
So risk-based screening is better.
Better,
it's
not even the same.
It's better. And why is it better? Because it absolutely helps you stratify risk so we can find the people at the highest risk, and the people we said were lowest risk are really at a lower risk. Now, this is the beginning, not the end of risk-based screening. But what we proved for sure was that the concept is we weren't going to be harming women. We said, look, what we picked stage 2B or higher cancers. So meaning, bigger cancer that was involving the nodes or was at least 2 centimeters and involving the nodes. Those are the cancers that are killer cancers. And at our highest risk group, where we were screening every 6 months, nobody had a stage 2B or higher cancer. So I think that's, really, really important. I think the genetic testing is a critical component. 75% of the women who were in the risk-based screening arm completed their genetic testing, which is great. And we just, that's just sending a spit kit to the door.
Right.
And sending it in. And, we relied on patient report. Pretty amazing. And, kudos to all the women who participated and stepped up.
It's amazing.
A really important thing. So we reduced the number of mammograms. We did not actually reduce the number of biopsies, and partly because I think, there's so many messages that women get about how they should screen every year or they should screen starting at 40. I think it's hard to follow a brand new recommendation that you aren't sure works. So now that we've shown that it's safe and probably better, and that we could probably reduce the chance of getting a stage 2B cancer by about 1/3, if everyone followed this, we could probably save 4,000 or 5,000 lives a year. And that's a big deal.
It's huge. Is that to get people to follow this, now that you've proven with such a good sized sample? Is this a medical education? Is this a marketing challenge? Like, what is it going to take?
Okay, there's lots of things that we have to do. First thing we have to do is get it into the guidelines so that the genetic testing is covered. That's the most important thing because, in order to run this study, we actually had to raise, through philanthropic dollars, all of the money to do the genetic testing.
Because insurance doesn't cover it?
Insurance doesn't cover it. And, we were funded by the Patient-Centered Outcomes Research Institute. I initially tried to make the case that this, to insurers to invest and help us generate the data. But the American health system is just so complicated. I just had to say, am I going to try and fix the healthcare system or I'm going to try and fix breast cancer? So I picked the latter and said,
Okay.
I'm just going to roll up my sleeves and raise the money. And, we're already on Wisdom 2.0. We're already trying to improve it. So there are two things that we do from the genetic test. We look for the errors in these certain genes that really confer either a very high risk or a moderate risk. We also look at a whole bunch of other genes. You have millions of genes that you inherit, and small changes in these by themselves don't mean anything. But as a group, many of them together, polygenic gene test risk, PRS or PRS scores, can actually really help you understand what your risk is. And that also probably changed the screening recommendations in about 15% of women. Importantly, though, we can do better even. We can start predicting who's at risk for slow-growing or hormone-driven cancers and who's at risk for triple-negative cancers or more aggressive cancers. And while we don't have, a prevention for that immediately, we have lots of good ideas. That's part of what RiseUp is about. And we have lots of ideas for how we can advance the field and start thinking about how we can bring more of this to bear. We've had a lot of attention to our website. It's finally Wisdom has finally taken off, right? And we're starting to really enroll people. Our challenge is we have to get it covered by the guidelines. Sadly, that's, in the best of circumstance, will take a year or two. We have to raise enough money to help get this interim group of women covered because, we don't want to stop. We don't want to lose the momentum. And because I want to be able to introduce new things. How do we predict who's got triple negative breast cancer if you're white? How do you predict who's got triple negative breast cancer if you're Black or Asian or Latina? And we have these tools and we're starting to test that. There's also new tools, AI for density, breast density. Everyone's been told, oh, you have to know your density, right? Well, it turns out that 50% of women have dense breast tissue. And if you're young, 60% of women have dense breast tissue. We can't be screening those people all the time. That would be way over screening. It would add $10 to $15 billion of cost to the system for not much gain. Turns out that using these AI algorithms, to tell you, you can find the 10% of people who really need more screening. And that's great. That's another important thing. But we have the capacity to look at all our data. We've got to invite all the people who are on Wisdom 1.0 who weren't on the personalized arm to be on the personalized arm and to use our updated tools. And if we had enough resources, we could figure out it's not just applying mammographic density algorithms, but what's the right threshold? How do you do? There's a lot that goes into it. But I'm hopeful that within a year we have something even twice as good as what we already had, and that we can really leapfrog over this. I think this is a real opportunity to be serious about identifying the people at the highest risk, working on breast cancer risk reduction. Instead of just sitting back and looking at 300,000 women be diagnosed, we should aspire to say, let's cut that number to 150,000. And let's cut the deaths from high-risk cancers,
right,
by a third. Why not? Why shouldn't we be doing that?
This is why you're you. I mean, it's a bold statement, but the thought that there are things available or coming available that if you knew your risk could reduce the probability of it ever developing into a cancer or could almost ensure that your cancer is caught early. And that was always a source of great comfort to me. Was I knew I was very high risk, both because of family history and genetic screening. I was screened every 6 months, as you know. Little side story. When I was diagnosed, Laura looked at my MRI from 6 months prior and said, "Wow, isn't that cool? It wasn't there." And that's what happens with a fast-growing cancer is it can show up pretty quick. But because we were looking every 6 months, it was found when it was small, not a
We were
big
able to give you the
threat.
treatment that we thought would work up front and know that it was going to work.
Exactly. And
And which
it
is
was
great.
always, but it was always a source of relief and I don't know, hope for me that I knew because of my risk, I was being screened and the probability was caught early. So many people I talk to, Laura, they wonder what they did that led to their getting cancer, particularly premenopausal women or perimenopausal women who might have even been too young for the standard screening. And
Well,
what
in
you're,
I Spy, 25% of women are under the age of 40. The average age is 46.
that's so
And
young.
you know what else is amazing that we found out? Of the women with these mutations, fully 30% did not have a family history. So if we just went on family history as a reason to do genetic testing, we would be wrong. And just because you have family history doesn't mean that you have a mutation. It's
Mhm.
also quite unusual. That's only 10% of people have a mutation. That's just not a good way to screen. A genetic test today is cheaper than a mammogram.
And you only have to do it once.
And you only have to do it once. We need to get over it and just start population-based screening. I would say, though, that it's super important for us to try and do this in the setting where we are getting outcomes. The importance of the wisdom study is that we can track people, we can learn, we can find out if we're doing prevention, is it working? If it's not working, what else can we do? It's so important not to just do stuff, but to do it and learn and keep making it
course.
better, faster. That's actually really important. So we now have made Wisdom 2.0 open to women starting at age 30 so that they can know. And you know what? If you are in the 2% of people who have mutation, you can, you want to be able to know this, before you have your children. So you can actually make a choice not to pass that gene on if you do, if you do pre-implantation genetics and you do in vitro fertilization. These are things that you can do. That's really important. And, we have a tool as part of Wisdom called Breast Health Decisions so that everyone on the trial has access to learn about your risk, learn what you can do to reduce your risk. And I think it's really something that every woman should know. And as I said, I hope that this is the standard of care, but I think it's important. It's not just about going out and getting a genetic test and having any algorithm. That's not what got tested. The Wisdom approach is to, we only do the extra screening for the people truly at high risk. Because, extra screening is, more is not better. More is just more.
That's right.
And sometimes more is worse, right? We're trying to also prevent overdiagnosis and overtreatment. So, you really want to have smarter screening, not more screening, smarter screening. And by the way, this happens to be one of those things that it's better and it's less costly and less impact on the women of this country. So it's such a win-win.
It's a complete win. And the other thing we are overdoing is we over-biopsy. And,
That's right.
that is incredibly uncomfortable.
Stressful.
And really stressful. And people don't realize, maybe correct the numbers. I had read 75% of biopsies are benign.
That's correct.
So we were doing screening, some unnecessary, some not enough. Genetic testing that isn't all going into a database, if you will, a way for us to learn and mine and track over time. And then we're over biopsying, and then we're over treating. It's just kind of a perfect storm of a mess. Or undertreating. Exactly.
Precision. We want precision screening, we want precision treatment, and we want precision prevention.
Yeah, when I went to the RiseUp conference last year, I loved in your opening, you talked about, you're a breast surgeon. That's your specialty. And you said, I want to stop doing preventative mastectomies. I want to do fewer mastectomies. I
That's right.
want to tell us a little bit about that. Because again, you're a breast surgeon. This is what you're trained in.
I'm actually I am an advocate for my patients. My field is breast cancer. It's one of the things that I work on and trial design. And my goal is to try and figure out how to prevent breast cancer, make treatments more precise, less toxic, and more effective. And one of the things I said, when I started treatment, when I started my practice, about 150,000 women were diagnosed every year. Now we're up to about 320,000, 330,000 this year, supposedly for 2025. It occurred to me that there are so many times that we intercede in women's health for cycle control, birth control, endometriosis, fibroids, IVF, postmenopausal hormone replacement, osteoporosis. Why are we not doing this with an eye towards breast cancer risk reduction? And it turns out that many of the anti-progestins like mifepristone and ulipristal acetate, we know that progesterone increases the risk of breast cancer. Anti-progestins should reduce it. In fact, there are people who are doing this kind of work. Super exciting. Why can't we use our imaginations and start rethinking what we are doing and start testing all these interventions and say, why can't we build a contraceptive that reduces breast cancer risk? Wouldn't that be amazing?
Yes.
Yes. What if we, that's the way to get rid of breast cancer. I don't want to just keep treating it. I want to prevent it altogether. There are things that we can do. So I've challenged people to think about this. And also, a lot of these agents, one of the reasons why this even came up in the first place was I was, initially not going to the San Antonio meetings because I was very upset about the decisions that were made to, criminalize abortion. And that's sort of what gave me the idea that, maybe we should be doing something also to really raise awareness on reproductive health. Here we are trying to save women's lives from breast cancers when there are so many easy ways to prevent people from dying from completely unnecessary complications because they can't get access to an abortion when they need it. And just for example, there are 1 million women who experience a miscarriage in this country every year. About 20% of them will need to have a DNC or an abortion because,
are those the same
to
thing?
prevent complications. Just simple that if we had abortion that was illegal everywhere in this country, 200,000 lives would be lost. That's 5 times the number of people who die of breast cancer. We cannot turn a blind eye to some of these simple things. And it turns out that a lot of this is related. I actually think that many of these agents that we use can be used to reduce your chance of getting breast cancer too. And that's what led me to start the meeting. But the meeting has taken on a life of its own, which is there's so much more we can do. There's this huge craze for a hormone replacement, but we need to design better hormone replacement. We need to do the studies to figure out what's working, what's not working. We need to really establish a standard for a set of tools for assessing how well breast cancer interventions to reduce risk work. Think about what we do in cardiology. We have that's what they did in cardiology. They did a big nationwide study to understand what the breast cancer risk factors were. Blood pressure is one of them. Cholesterol was one of them. They did the studies to show that lowering your cholesterol, lowering your blood pressure, reduce the chance of getting heart attacks. Now, if you want a better drug, you just do it up based on blood pressure. You just do it based on cholesterol lowering. It's time for us to do that in breast cancer. So we can develop imaging tests, different ways of doing this. we need to stop saying, oh, we can't do it, and say we can do it, right? They did it with the
Right.
Birmingham study and heart disease. Heart disease used to be the biggest killer for women. Now it's cancer. I have envy. I want to make that change. I know we can do it, right? And so February 19th to the 21st, that is our meeting. Super exciting.
Can anybody come? Is this like open to the public?
This is an area that you are really interested in. You can register. We also have a meeting, a luncheon where we are trying to raise money for what I call the Spark Awards to try and figure out, well, who's got the coolest ideas for thinking about how to build better breast cancer prevention tools and drugs. And, whether from exercise to medicines to, weight loss to all these connections. All of women's health is related. Trying to reduce the risk from fibroids. Some of those medicines should reduce the risk of breast cancer. There's so many incredible connections. So many people want to know what to do about hormone replacement. Is it safe? Is it not safe? If you've had breast cancer, can you ever have it? We're going to talk about all those things. So go to riseup.ucsf.edu.
We'll put the link in the show notes. And I remember last year, and I'm a layperson, but it was so educational. And some of the things people are exploring, like what's the connection between GLP-1s and breast cancer reduction, risk reduction?
We have a whole session on that this year.
Amazing.
Yeah. Another thing is fatty liver or things like that. That also turns out to be increase your risk. We can get rid of that. But there's so many things we can pay attention to, but they're all interconnected. And the breast cancer people don't necessarily talk to the OBGYNs and people don't know enough about risk. We're trying to bring the primary care physicians, the family physicians, the OBGYNs, the researchers who are doing the work across all of this and bring them together so we can learn together. And so that we can ask, how can we do it better? How can we do it differently?
It's a great question. So before I let you go, and I do think we should do it like a GoFundMe for wisdom, because I think you need $4 to $5 million to make it available to more.
Because I don't have patience to wait. I can do 7 years worth of work in 1 year if I have that resource. And then I don't have to close the trial to enrollment until I wait for the guidelines to change.
So let's help figure out how to do that. But I want to ask you one rapid fire question. What's your advice to anyone who wants to kick cancer's ass?
Get educated, get informed. If you don't have cancer, join Wisdom. But help me raise money so I can keep this study open.
Exactly. And let's get personalized screening, risk-adjusted screening.
Get educated, get informed. It's not an emergency, right? But everyone has the time to learn and learn about their own risk and learn about what they can do. And don't be afraid, because you either have the risk or you don't. Better to be forearmed. Forewarned is forearmed, right?
Always felt that way personally. Laura, thank you so much for joining me. I know we've had our technical ups and downs on this, but you are a force of nature. I am so glad to know you and so privileged that you were part of my healthcare team.
Well, thank you so much for having me, Joelle, and thank you for spreading the word and doing all the work that you're doing. That's how we're going to make a change. But
we're going to get people educated.
We can aspire to better, and we can make it happen. We can really make those words, you have breast cancer, so much less frequent. We can do it, but we have to have the will and the resources.
Well, let's see what we can do for it. Thank you again. We never choose the pitch, but we always choose the swing. I'm Joelle Kaufman. This is Kicking Cancer's Ass. If this episode inspired you, enraged you, made you advocate for personalized risk-adjusted screening for your body, please share it with somebody else. And please support the Wisdom Study. Join us at UCSF RiseUp for Breast Cancer and Women's Health, February 19th to the 21st. I hope to see you there, and let's learn about all the great ways we are discovering to kick cancer's ass.